All right, everybody, thank you for joining. We kind of slowly have some people coming in here. Give it a second for everybody to log in. Thank you for being here for another one of our monthly webinars. It is February, which means it is American Heart Month, and we have a really exciting, interesting topic today with a great speaker. Our topic is heart disease in women, and our speaker is Dr. Lisa Freed from Yale New Haven Health. And before I kick it to Dr. Freed, I'm just gonna talk a little bit about her and give her a little bit of an introduction. And before I do that, I just want to say I've had the opportunity to hear her talk and present, and you guys are in for a really informative, impactful presentation. So Dr. Freed has been in clinical cardiology practice since 1999 in the greater New Haven area, specializing in women and heart disease. She completed medical school at the Johns Hopkins University School of Medicine and residency in internal medicine at New York Hospital Cornell Medical Center. She completed cardiology fellowship at Massachusetts General Hospital, Harvard Medical School. While there, she also concentrated on echocardiography, performing research on mitral valve prolapse at the Framingham Heart Study. She's board certified in cardiology and echocardiography. And in addition to caring for her patients, Dr. Freed has been an avid advocate and lecturer for women and heart disease. And she now serves as the director of Yale New Haven Hospital's Women's Heart and Vascular Program. So thank you so much, Dr. Freed, for being here. We really appreciate your time. And I will kick it over to you so you can take it away.
Thank you, Mike. Thank you for inviting me, and thank you to FitCheck for asking me to speak. It's my pleasure to be here, and I'm going to speak today. The topic of my talk is Never Too Old or Too Young, a guide to a healthy heart for all generations. Just as a preview, I'm going to be talking about three women who are fictitious, so there's no HIPAA issues here. These are women that I've made up that are kind of a conglomeration of my experience of caring for women, and I'm using them as an example to point out cardiac risk factors and treatments for women. So we're going to start by telling the story of Clara's heart. So Clara was born in 1948, and she's a healthy baby girl, and there she is. She's adorable. And what Clara and her parents don't know is when you look at what's going on in the world and look at deaths attributable to diseases of the heart, you can see that there actually have been starting to rise. And in 1948, when she's born, they're really on a pretty acute curve of rising. And of course, Clara and her parents don't know this, but we're going to find out what happens to Clara as she gets older. So when she's 1 year old in 1949, there she is eating her birthday cake. We know that the diet of that time is not particularly heart healthy. People are drinking whole milk, they're frying things, and they're happy because they eat lard. Interestingly, in 1938, about 10 years before Clara was born, the British Medical Association, based on research that they used from the 1920s and 30s, recommended that British people should drink 80% more milk. And again, we're talking about whole milk, 55% more eggs, 30% more meat, and 40% more butter. And so we can see that how Clara's diet actually does reflect that. In 1948, the Framingham Heart Study began, and that was a study that began to recognize that more people were dying of coronary artery disease, and the study began in order to try to identify the risk factors that was causing that. So already we have a sense that some of it was what people were eating. In 1950, so 2 years after Clara was born, an American doctor, John Goffman, put forward a hypothesis that blood cholesterol was to blame for the rise in coronary heart disease. And they identified LDL, which is the bad cholesterol, and HDL, which is the healthy cholesterol, the good cholesterol at that time. And in 1951, just a year later, pathologists in the Korean War were autopsying bodies of dead soldiers. Their average age was 22 years old, and they actually discovered that there was coronary artery disease in over 75% of all the men that they were autopsying. That's not what they died from. That's just what they discovered when they were doing these autopsies. And of 300 that they had in this study, 35% of these on average, 22-year-old men had deposits of fibrous fatty material that were sticking to the artery walls already. 41% had fully formed lesions, meaning plaque lesions, and 3% of lesions blocked at least one coronary artery already at the mean age of 22. So this diet was already beginning to look like a problem. So what do we know now? What about lipids for women now? We know that for much of their adult lives, women have healthier lipid profiles than men. Their total cholesterol and their LDL, which again is the bad cholesterol, levels remain lower than men until after menopause. So they get this like 10-year period where their lipids are better than men, or 10 years longer than men. Their HDL levels remain high before menopause ensues, and those levels begin to decrease as menopause happens. The cholesterol can continue to rise, and generally that's the LDL, well into a woman's 70s. So even if their cholesterol profile looks great at 40, 45, by 70, 75, it may not look as great. And among all the known risk factors for coronary disease in women, the dyslipidemia or elevated cholesterol has the highest population attributable risk, meaning that if there was a reduction in cholesterol, they would be, that many less would die if they were unexposed. So again, a very potent risk factor for women. What about treatment? What do we know about treatments for lipids in women, since we've now just discovered that they are important for causing coronary disease in women? Medications called statins, things like atorvastatin, which is Lipitor, or rosuvastatin, which is Crestor, or simvastatin, pravastatin. These are all statins. Those are equally effective in women as in men, in what we call secondary prevention, and then also in primary prevention. Secondary prevention is when people have already had a heart attack or a stroke. Primary prevention is before any event has happened. And there was a trial called the Prove It trial, where people after acute coronary syndromes were randomized to high-dose statin therapy versus a standard statin dose, and they had a 25% reduction in cardiovascular events and mortality. So we have proven, and this is just one study of many, that statins are effective in women and should be used. In primary prevention, where people haven't had events, there was a meta-analysis of over 174,000 people, about a third of whom were women, and that for every 18 points that women were able to lower their LDL, there was a 15% reduction in cardiovascular disease. So equally effective whether women have had heart attacks or have not, and should be used in women. Problem is they're not always used in women. Women are often undertreated. In 2016, there was a study from Brigham Women's Hospital and Mass General of over 24,000 patients with coronary disease, and women were statistically less likely to be treated with statins. Notice the date here, 2016. This is pretty recent as time goes for treatment, and still we're not doing a great job with treating women. And there were 4 factors that were felt to be responsible. The women were less likely to have been evaluated by cardiologists, so they weren't referred to cardiology. The women were more likely to have reported an adverse effect from the statin, so they were just withdrawn and not tried again or tried differently. Women were older, and women didn't smoke. People tend to give statins more if people were smokers to try to balance out the risk effects, and we'll talk about smoking a little bit later. There was a study in 2017 from a place called the National Medical Expenditure Panel survey of over 157,000 patients, half of whom are women, and it showed among all the subgroups, statin use was significantly lower in women. So again, a big problem and something that we should be aware of. There is one other piece of data I want to show you on this, which comes from the women's guidelines. There weren't always women's guidelines for cardiology, but there are now, and the most recent one that came out was in 2020, and they looked at the use of statins for prevention in women. This is now prevention of heart disease, and they basically split women up into 3 different groups. The women who should absolutely use a statin, and those are the people for secondary prevention who've already had a heart attack. women who haven't had a heart attack yet, but whose LDL was greater than 190. That was the cutoff that was found to be the most effective. Women with diabetes, and we'll talk about that a little bit later. And then primary prevention in women between the ages of 40 and 75 who are at high risk or intermediate risk for coronary disease. And there were a few other what they called sex-specific risk enhancers, which was premature menopause and pregnancy-associated conditions that increase the risk. And we will talk about both those things a little bit later. The women who absolutely should not or take statins or don't need them are people who were at low risk between the age of 40 and 75. And we'll talk a little bit more about how we figure that out. In pregnant women, statins have not been approved yet for women in pregnancy. And then the people who it becomes a conversation. Should I be on a statin? Should I not be on a statin? Those are women between the age of 40 and 75 years who are at borderline risk. And so that then becomes a discussion between one's primary care provider or cardiologist and the patient. So we're going to move on to a few more Clara's risk factors. So Clara is 1968. She's 20 years old and she's feeling very anxious. She's stressed. And so what does her doctor recommend? He recommends smoking. And that was actually not so uncommon back then. Smoking was thought to be a relief for anxiety, for stress, and it was recommended for men and women for that reason. And they even used physicians to advertise the cigarettes. More doctors smoke Camels than any other cigarette. Here's an ad that says that it's a psychological fact that pleasure helps your disposition, and for more pure pleasure, have a Camel. So they were actually advertising it for that reason. And then on top of all of that, there were ads that were directed at women to try to imply that if women smoked, they would become equal with men, or they would, rise in status. And the end of the ad always says, "You've come a long way, baby," meaning that you've risen in status and you're more like men if you smoke. So this actually did happen quite a bit. I've had patients that were recommended to smoke for this reason. And it's a big problem for women, and I will tell you why. Men who smoke have their first heart attack an average of 7 years earlier than male non-smokers. Women who smoke have their first heart attack 19 years earlier than female smokers. So smoking is actually a much more potent risk factor for heart disease in women than in men. And do we know exactly why this is? We don't know exactly, but we believe that it's an interaction between smoking, which can cause your blood to be hypercoagulable or increase sort of the thickness of your blood, and then estrogens, which also can do that in premenopausal women. And so it may be the interaction of the two, though that's not been specifically proven. We do know, though, that women do die more if they're smokers. And if you look at this meta-analysis, in all age groups over 45, women have a 25% increased risk of coronary disease conferred by cigarette smoking as compared to men. So this was a big disservice that Clara's doctor did for her. We're going to move on to a few more of her risk factors. So far, Clara's kind of racking up the risk factors for heart disease as her life goes on. So in 1988, now she's 40 years old. And she begins to get heavy bleeding with her periods, and she becomes pretty anemic. So she sees her gynecologist who recommends a total abdominal hysterectomy. And by that, we mean take out the uterus and take out the ovaries as well. The doctor says you have 2 children and now you're old, so you don't really need those parts anyway. And she has no discussion about hormone replacement therapy or effects on her overall health with the loss of her estrogen and progesterone, but she has the surgery. And so what do we know about that? In the United States, the hysterectomies are the second most frequently performed major surgical procedure among reproductive age women. It's approximately 500,000 a year. That changes a little bit and actually has gone down a little bit through the recent years. There is a positive association, and in this case, positive doesn't mean good, with removing both ovaries and increased risk of cardiovascular diseases in observational studies. The Nurses' Health Study is an observational study that's been going on for decades, where they have nurses fill out questionnaires. The vast majority of them are women, about what their risk factors are for coronary disease. Are they smoking? What's their diet like? Do they exercise? Have they had a hysterectomy? Are they on hormone replacement therapy? And then they look to see what happens to the women. They don't intervene, they just observe. And so there definitely has been an increased risk of cardiovascular disease in women who've had their ovaries removed prematurely. So what does premature menopause really mean? It's menopause at age 40 or less. There's an increased risk of cardiovascular disease, as we said. And what happens is there's changes in fat distribution, reduced glucose tolerance, meaning blood sugars go up, abnormal lipids, meaning LDL increases, which is the bad cholesterol, and HDL decreases, which is the good cholesterol. They have higher blood pressure. They have increased sympathetic tone. The sympathetic tone is the flight or fight tone, the adrenaline. And then endothelial dysfunction, meaning the inside of their arteries start to malfunction or not work properly. And then there's vascular inflammation. We know that inflammation is a risk factor for coronary disease as well. So a whole cascade of bad things happen once one hits menopause or has premature menopause. So you want to stave off menopause as long as you possibly can in that regard. The only other thing I do want to say about it is, although it sounds like the answer should be give hormone replacement therapy, that unfortunately is still fairly controversial in the cardiac world, because there have been negative outcomes of trials with hormone replacement therapy. So the American Heart Association and the American College of Cardiology still say that hormone replacement never should be prescribed for the express purpose of preventing coronary disease. That's not to say that it can't be used if people are having severe perimenopausal symptoms. And what the consensus is for that is that you can give hormone replacement therapy, but they recommend at the lowest effective dose, and for as short a period of time as you can, as long as the person hasn't had a recent heart attack or a stroke, which would be a contraindication to doing so. So this is still a very difficult problem and still a work in progress, I would say. Moving on to some more of Clara's cardiac risk factors. That same year that she has her hysterectomy, her mother dies suddenly at age 60. It's a presumed heart attack, as her death was preceded by several hours of chest discomfort. And I just wanted to touch for a minute about family history of premature heart disease. It's considered heart disease in a male first-degree relative who's less than 55 years old, and a female first-degree relative who's less than 65 years old. So for Clara, her mother dying at 60 would be another cardiac risk factor. It's important to note that most of the risk factors that I've talked about so far are preventable ones. If your lipids are elevated, and we will get to blood pressure, if your blood pressure is elevated, if you have diabetes, these are things that one can act on, can treat with medications, can change lifestyle. Family history is something you have to work around. And so that's one of those immutable risk factors that you have to factor in, but trying to work against by fixing all the risk factors that you can change. There actually was an American Heart Association study that showed that just by changing the preventable risk factors, you can lower your risk of heart disease by 80%. So you can make a huge difference by changing lifestyle and taking medications. Okay, so let's go on to Clara needs to see a doctor, is the bottom line. She needs to get a primary care doctor. She's now 54 years old and it's 1992. So she sees a primary care doctor who's down here. She's not looking terribly happy at this point. Her diet is still high in fat and cholesterol. She continues to smoke. She has been in menopause for 14 years since her hysterectomy. She shares the history of her mother's sudden death with her doctor. Her blood pressure at this appointment was 162/94. When it was taken at her gynecologist the year before, it was 152/90. And we will talk about guidelines for that in a minute. Her body mass index is elevated at 32. Just to refresh your memory, over 25 is considered overweight and over 30 is considered obese. So she's heavy. Her total cholesterol is 285 and her LDL is 195. And if you remember the kind of, yes, you should definitely treat for LDL in the women's guidelines is 190. Her fasting glucose is 120, and we'll talk about that in a minute as well, but that's elevated. Greater than 100 is considered elevated. And so his response, and I'm going to tell you before I give you his response that his response right this minute is not the right one, but we will go over the right one. But this is what happens to women when they do get undertreated. He says, work on diet, but he doesn't give her any specifics or refer her to a nutritionist. He said, add some exercise, maybe once or twice a week. He tells her to stop smoking, but doesn't really give her a lot of help as to how to do that. And he says, come back in a year and we'll see how you're doing. And that's the end of the visit. And so Clara walks away and I guess tries to do some of those things. But what we know now is that that wasn't the best advice for Clara. So just to refresh your memory, this is 1992 that she's getting this advice. These are cardiovascular mortality trends for US males and females from 1980 here to 2020. The red line are the women and the blue line are the men. And what we saw is back in 1980, more men were dying than women of heart disease. But that line crossed over in 1983, and more women started to die than men of heart disease. And you see this continues to rise for quite some time until 2000 or so, when it starts to go down, but still more women are dying. It finally did cross back over again around 2013, 2014. And so when he's telling her in 1992 to kind of do some vague things without offering her any treatment, he's not doing her any favors in that regard in terms of her heart disease. So a few just facts about that. As I said, in 1983, more women started to die than men of heart disease. The treatment of hypertension in women was well established. Her blood pressure was not treated by him. Statins for elevated lipids had been available since 1987, but she wasn't offered one in 1992. And in 2005, interestingly, after this date of 1992, the American Heart Association polled physicians, which included primary care doctors, OBGYNs, and cardiologists. And at that point, fewer than 1 in 5 physicians knew that more women than men died from heart disease every year. And what they found to be kind of the tipping point for whether these doctors treated the women was their perception of risk. So if they didn't think that women were dying, they didn't bother to offer them proper hypertension treatment, proper statins, good advice on how to lose weight, how to stop smoking. And if you poll, when they poll, and they've done this regularly, they polled randomly selected women about what their thoughts were on the leading cause of death. In 1997, only 30% of women knew that heart disease was their leading cause of death. It went up in 2009 to 65%. And in 2004, the Go Red for Women campaign started by the American Heart Association. So they did actually have an impact with the onslaught of that program. And that meant that you saw it on news shows in the morning. You saw it in newspaper ads. Doctors were getting lectures. I was at the time going out in the community, talking to church groups, talking to schools. Anyone who wanted a lecture on heart disease, I would go and explain how it affected women. Unfortunately, that number has started to slide back a little bit. In 2012, only 56% of women knew, and in the most recent one, it had slid back to 44%, telling us that we still need to do these sort of lectures and keep this problem foremost in people's minds, or women's minds at least, and their physicians. So that is what we know. What her doctor really should have said, so there are all her problems again, is it should have been specifically work on your diet, a low sodium diet for her hypertension, which means less than 2 grams of sodium a day. To work on a low fat, low cholesterol diet for her lipids, and then work on carbohydrates for her elevated glucose. And generally, when someone has this many issues that they need to deal with, seeing a nutritionist is a really good idea, because they can help you balance and figure out how your diet should look to maximize the effect of diet control. Adding exercise for the hypertension guidelines is at least 3 times a week. For all the other guidelines, it's most, if not all days of the week, is 30 minutes of exercise a day is ideal. Stop smoking. There's many ways to do that. You can try nicotine patches, you can try gum. There are medications that can be used. So giving very specific instruction is usually better. Sometimes people do better with cold turkey. Sometimes they do better weaning themselves off the cigarettes. There's many ways, and it often takes many visits to get people to find the way that's best for them. But it's also very important, especially for women. She should have been started on a medication for her hypertension. She had been hypertensive at least a year that we knew of. There was no reason to wait. Implementing diet controls, low sodium diet and exercise is great. And sometimes people want a try to do that first, but giving them a year to try is only, really prolonging the damage to their heart and their kidneys from the hypertension. So maybe 3 months later, you try diet and exercise, see if it's making a difference, and then you start a medication, or it would be reasonable to start one at that visit with her primary care doctor. Giving a medication for her lipids, she is already over the limit and probably has been for some time. Again, if she wanted to try with diet and exercise first, would be reasonable since she hasn't had an event. But starting one pretty soon would be reasonable. And then checking something called a hemoglobin A1C, which is a 3-month average of the glucose, would be a reasonable thing to do since her fasting glucose was elevated, to see if she fell into the pre-diabetes or diabetes category. So that's really what he should have done when he saw her and she was asking for help. So let's just spend a minute on the recent guidelines for women and hypertension. From that same set of women's guidelines that was published in 2020, they had this nice little graph which sort of sums up what one should be thinking about. We know that the prevalence of hypertension increases after menopause. And so you want to work on prevention. If you're not hypertensive yet, maintain a normal body mass index, moderate salt intake, increase your physical activity, and limit your amount of alcoholic beverages in a day. Technically, no more than one is what's recommended, 4 to 6 ounces of wine, something like that. If you're unsure about one's blood pressure, maybe you have some white coat hypertension and you get very hypertensive when you go to the doctor. There is something called ambulatory blood pressure monitoring, where you can actually wear a cuff for 24 hours and it will check your blood pressure through the course of a day. And some of my patients will get the automatic cuffs and check at home when they're calm and in a happier surrounding to see if they're still hypertensive. Ideally, the therapeutic target is less than 130/80. And ideal is obviously 120/80 or lower. And so the recommendation, just so you know, that women aren't included in many of the historical trials for cardiac risk factors or heart disease. And so the recommendation that is made for all people, the trial that's based on only enrolled 36% women, but we all feel that that's adequate to treat women the same. The guidelines should be the same for women and men. And when they do look at large outcome trials, there's no difference in men and women based on the regimen that's offered to them. So really any medication is fair game for women so long as they're not pregnant. And women may experience more side effects than men, and that just means their doctor needs to work with them to tailor the regimen that works for them best. The only medication that has been proven to be slightly better for women than for men are thiazide diuretics. Hydrochlorothiazide is the most common one of those, and it's only beneficial because it reduces calcium excretion. It's a little better in preventing osteoporosis, but really any medication that works and is side effect free or has limited side effects is the best choice for a woman. And then I'm going to spend literally just 2 slides on diabetes. Diabetes is like a week-long seminar, and I'm going to reduce it down to 2 slides just to give you a sense of it. There are differences for diabetes in women and men. Girls tend to have a higher incidence of type 2 diabetes in youth. Men have a higher incidence in midlife than women. And as you get to later stages of life, type 2 diabetes is pretty even in men and women. Diabetes increases the risk of heart attack or stroke by 2-fold. And if a woman, and that's in women, if women have diabetes before they get to menopause, that 10-year protective period that they get for heart attacks and strokes and better lipids is actually reduced. So it is a bad actor for women in general. It's a bad actor for women and men. When they look at the mortality from cardiovascular disease in women and men with diabetes, for women, it's 2.2, and for men, it's 1.86. So there's a greater excess mortality in women versus men, but it's not good for either of the genders. Treatment, again, 1 page on something that should be a week-long seminar. All patients with diabetes require aggressive risk factor reduction. There's no sex difference between treatment and target for diabetes. That hemoglobin A1C, which is the 3-month average of the glucose, the goal is less than 7% for men and for women. Like blood pressure and lipids, women are often underdiagnosed and undertreated compared with men. So again, something to be aware of when you see your primary care provider to make sure that your diabetes or prediabetes is addressed. So let's see what happens to Clara. So she saw that doctor, 20 years later, now she's 75, it's 2023. She never really lost the weight. She tried to quit many times, but she's unsuccessful. She has too much stress in her life. She takes care of her husband who has had a heart attack, and she babysits her grandchildren. So she's sort of busy all the time and doesn't have a lot of time to expend the energy at smoking cessation. She was started on some low dose blood pressure meds. And she was able to lower her LDL with diet and some exercise from 195 to 160. So her doctor's happy and they don't ever start a statin. So what happens to Clara? She's shopping in the supermarket with her husband and she has some chest pain. She tells her husband. He gives her some Tums and from his pocket, and he tells her he's a little tired. He's going to wait for her in the car while she finishes up shopping. She keeps shopping and feels a little weak. She leans over her cart. A kind stranger asks her if she's okay, and she says she's having chest pain, and the stranger finds the manager and they call 911. So what happened? Why didn't Clara say, hey, I'm having chest pain, let me get to the hospital? Or why didn't her husband say, oh my God, you're having chest pain, maybe we should do something about that? They've actually studied this since the 1960s. And this is called lay consultation. What do people do when they start having chest pain? And it's been shown for women that the longest delays to getting to the hospital is if they're alone. So if they're consulting with themselves, oh, I'm having some chest pain, oh, maybe it's something I ate, maybe I pulled a muscle, it's not really my heart. And then the second longest delay is actually if they tell their spouse. The spouse will say, oh, you know what, you had that indigestion last night, you take my Tums, or, I'm sure it's nothing, let's get our shopping done and go home. The shortest delay to getting to the hospital is if they tell a complete stranger. And you can imagine that if you were walking along the street and somebody didn't look well and you asked them what was wrong and they said they were having chest pain, you take out your cell phone and you call 911 and get them to help as fast as you could. And so that's an important fact to remember, that it's important to listen to your body. If you're having chest pain and you haven't had it before, or it seems like it could possibly be coming from your heart, you should call 911 and go to the hospital, get it checked, and not, consult with yourself and delay, or consult with your spouse and delay. There are other built-in delays for women's care, and I just wanted to go over some of those. There's definitely gender differences. There are several studies over the past couple of decades that have been done, and I'm just going to highlight a few of them. We know that there are delays to hospital presentation in women and men with heart attacks, and there was a multi-center analysis of hospitalized patients in New York in 2022. They looked at 218 patients with STEMI, is ST elevation myocardial infarction, which just means your classic occluded vessel Hollywood heart attack. And these were treated with primary angioplasty. That's that balloon that opens up the vessels at 4 New York City hospitals. And of the 218, 24% were female, and the mean age of the women were 68.7. So they're about 69 years old. And the women with heart attacks had longer pre-hospital delays than the men. And I will show other studies. This is not the first time this has been seen. Compared to men, a smaller proportion of women thought they were having a heart attack. And just like that statistic of awareness that I was showing earlier, this is what that results in. If you're not aware that heart disease is a leading cause of death, you're not going to act on it. And so that's what they said. They didn't think they were having a heart attack. They didn't call 911. And a larger proportion of women than men had a symptom to presentation time of greater than 90 minutes. The reason why we care about that 90 minutes, there's something called door to balloon time, meaning from when you get to the hospital with your chest pain to when they actually open the vessel with the balloon. And 90 minutes is considered to be the amount of time that your heart can withstand not getting enough oxygen before it starts to die. And so that door to balloon time is critical in the world of cardiology and in the world of heart attacks. Women were also more likely to hesitate than men before seeking help, and more women than men hesitated because, again, they thought they weren't having a heart attack. When they looked at all the factors that could have made them delay their care, female sex, subjective opinion that it was not a heart attack, and education level less than high school were all independent predictors for longer symptom to presentation time. So again, the article concluded that a greater focus should be made on educating women and men regarding the symptoms of heart attack, and the importance of a timely response to these symptoms. There was another study in 2012. This one was in San Diego, so across the country a few years before, that looked at people who presented with heart attacks. Again, there was 204 men, so a little bit larger study, and 99 women. And the mean difference from scene time, from when 911 was called to hospital time, was about 4 minutes. Women were delayed by 4 minutes compared to men. And the reason suggested it this study was that they didn't always have chest pain, as you know, and we're not really going to talk about this so much in this lecture, but women tend to have a higher proportion of atypical symptoms when presenting with a heart attack. The most common presenting symptom for men and women is, in fact, chest discomfort. And it can be a pressure or a tightness in their chest. But women can sometimes not have chest pain and just have shortness of breath, or just have shortness of breath and nausea, which are other presenting symptoms. So in this study, they didn't always have chest pain or classic chest pain. There were no history of coronary artery disease in the women, so the EMS people moved a little slower because they hadn't had heart attacks before. The women were older, and there was a lower sense of urgency because, again, women delayed calling. When they did a calculation in this study, that delay of only 4 minutes would translate to a possible increase in mortality and death for the women of 0.25 to 1.6%. So each minute means something for these women. There was a larger study, again, 3 years before that, that looked at almost 6,000 individuals who had made a 911 call for chest discomfort. And on average, the women arrived 3.3 minutes later than the men. And they had a 50% greater odds of being seriously delayed, greater than 15 minutes. So this is a consistent problem. And what's interesting is it's not only a consistent problem here, but it's actually a consistent problem in European nations as well. There was a study in 2015 that looked at about 7,500, again, STEMI patients, a third of whom were female. And once again, in the pre-hospital setting, women had a longer median time from symptom onset to call for help, and then a longer delay in getting to the hospital after contact with emergency medical services. So this study put both of those aspects together. Women delayed, and it took longer to get them there. And interesting, the range of delay was anywhere from 5 minutes to 3 days. I don't exactly understand that. Probably the women sat home with the chest pain for a couple of days before they called, is what I'm guessing. So anyway, what happened to Clara? So here's a picture of Clara's artery, not really Clara's artery, but here's a picture of what Clara's artery could look like. And this is a artery that is shown with like the front of it missing here, so we can see the blood. Here is the cholesterol plaque that was in her artery. Here are the little blood cells going through. And then what happens is in a heart attack is a plaque will rupture. And when that ruptures, the body views it as a break or a breach, and it sends platelets and clotting factors over to that area, and that generally will clog the vessel up entirely. And so that's what's going on here. You can see the blood is looking thicker and sludgier right around the breach of the plaque. And so EMS notes that there's an anterior or a front wall heart attack on Clara's EKG and calls ahead to the emergency department. And she's brought to a place called the cardiac catheterization lab, where they'll do an angiogram or pictures of her arteries and look to see if they can do a balloon angioplasty and put in a stent. So I'm going to leave you in suspense as to what happens to Clara here, and I'm going to actually go on to the rest of her family. So we're going to meet Clara's daughter, Marie. Now, Marie was born in 1969, and she's now 54 years old. And she decides after Clara's heart attack that she maybe should see a primary care doctor as well, because she hasn't really been too good with keeping up with her health either. She has actually a pretty healthy diet, but unfortunately her LDL is still pretty elevated, though not over 190, and her hemoglobin A1C is 6.4. Normal is less than 5.7, and I'm sorry, her hemoglobin A1C is 6. Normal is less than 5.7, and prediabetes is between 5.7 and 6.4. Over 6.4 is considered diabetic. So she's in the pre-diabetes zone. She smoked too, emulated her mother, and she started at age 14 and smoked a pack per day since 1983. She too has come a long way, baby, because that's a Virginia Slim ads from her generation. And she's perimenopausal, and her blood pressure is elevated. And her family history of coronary disease is now in her mother and her grandmother. She also had a recent calcium score of 265, and I will go over what that means in just a second. She has an EKG, which is normal. So let's see what we can do to help Marie. She hasn't had a heart attack yet, and we want to prevent that, right? So taking lessons from what happened to Clara, we're going to recommend that her blood pressure gets treated right away. We're going to treat her lipids, and we're going to really work with her for smoking cessation. We also want to examine with her the significance of her elevated calcium score. So what is a calcium score? It's a fairly new recommendation by the American College of Cardiology, American Heart Association. It's a CAT scan that uses low dose radiation and does not use contrast to look at the coronary arteries. It actually can map out all of the coronary arteries and tell us how much calcium, which is a correlate for plaque, has accumulated in each artery. So it gives us kind of the concept of lifting up the hood and looking at the engine directly to see if anything is clogging up. It's recommended for adults between 45 and 75 years of age who don't have diabetes, because remember, diabetes is an automatic, you should be treated with a statin because we presume that there's vascular disease when people are diabetic, who have LDL levels between 70 and 189, because remember, over 190 is when you treat automatically anyway. So these are people who you're not quite sure if you should be treating, and have kind of an intermediate risk for coronary disease. And if the person maybe has some of the things that you would treat with a statin, but they're uncertain whether they want to be on a statin, this is another way to look to see, well, should you really be on one or should you not? If a calcium score is 0, then you have a little bit of flexibility, because although your cholesterol might be high, you don't seem to be depositing in your arteries. So at that point, you don't have to be on a statin. It can be withheld or delayed. The only time we tend to shy away from that is if somebody is an active smoker, or they have a very strong family history for coronary disease. And obviously those with diabetes, they should have been on a statin anyway, because not only do the large vessels clog with people with diabetes, but the microvasculature, which we don't see in a CAT scan, can be clogged. If someone has a calcium score between 1 and 99, that favors giving statin therapy, especially if they're greater than 55 years old. And if they're greater than 100, and I don't know if you remember, but Marie's was 265, again, statin therapy is really indicated, is recommended, unless there's, some other negative side to being on a statin. So that's the use of a calcium score. And Marie, given all her other risk factors, I'm not sure she actually needed a calcium score, but that was certainly added information that she's going down the same path as her mother and her grandmother and should be treated aggressively. So that is Marie. And now I'm going to also talk about Clara's granddaughter, who's Olivia. And Olivia was born in 1995, and she's 28 years old. And she is on a heart healthy diet, and her LDL is, reasonably good for her age, and her hemoglobin A1C is absolutely normal. She never smoked cigarettes, and she is currently pregnant. She's 36 weeks pregnant, and her blood pressure, unfortunately, is elevated. She, again, now has a family history of coronary disease in her grandmother and her great grandmother, and her mother, we're trying to prevent her having active coronary disease in. Her EKG is normal. Unfortunately, her urine dip is positive for protein, which means that her clinical presentation is consistent with preeclampsia. So Marie, like Marie, Olivia also needs treatment. And so what do we know about preeclampsia? I'm going to actually now refer back to those same 2020 guidelines, because they had data in them which was new for the women's guidelines. We know that adverse pregnancy outcomes occur in 10 to 20% of all pregnancies and are associated with a 1.8 to 4.0 fold risk of future cardiovascular disease. The risk of cardiovascular disease is higher if there's a more severe form of adverse pregnancy outcome, and I'm going to go through what those adverse outcomes are. And also, if more than one pregnancy is complicated by an adverse outcome, it's a higher risk to the mother. The thinking is that abnormal placental dysfunction may correlate with endothelial dysfunction, that dysfunction we talked about earlier, where the inside of the vessels can act abnormally and cause coronary disease later on. And we also want to recognize the importance of these adverse pregnancy outcomes in younger women so that we can counsel them about their future much earlier than 54, when Clara and her daughter went to the doctor. So what are those adverse outcomes? Hypertensive disorders of pregnancy, gestational hypertension, meaning hypertension after 20 weeks of gestation, chronic hypertension where people were hypertensive before they were pregnant or before 20 weeks of gestation, preeclampsia, which is new onset hypertension after 20 weeks, and protein in the urine. And then there's also gestational diabetes, where you develop glucose intolerance with pregnancy. Then other adverse outcomes of pregnancies are pregnancy loss, either a miscarriage or a stillbirth, preterm birth, where you deliver before 37 weeks, early preterm, which is before 34 weeks, small birth weight, or what we call intrauterine growth restriction. And all of those things, and this is a table from that same set of 2020 guidelines, can lead to cardiovascular risk later on in your life. So part of taking a good cardiac history now is asking about those events, which we did not used to do until 2020. And the recommendation now is once you get through your pregnancy and treat those issues, that 3 months postpartum, you should be evaluated for all your other cardiac risk factors, and they should be addressed aggressively. So you don't wait till you're 54 to deal with it. So we recommend for Olivia, treat her blood pressure now while she's pregnant and follow up with her 3 months postpartum and, deal with her other risk factors if there aren't. So that's Olivia. So what happened to Clara? Clara did great. She underwent a stent to her left anterior descending artery, which supplies that front wall of the heart. She's now on all the appropriate guideline-based medications. She stopped smoking. She has a heart healthy diet. She lost weight. She exercises at the senior center 5 days a week. Marie bought her an Apple Watch, and she always knows her numbers, meaning her blood pressure, her lipids, her glucose. Marie and Olivia, cardiac risk factors are under control, and everybody is doing well. So what are our take-home messages here? Know your numbers. You want to know what your blood pressure is, what your lipid panel is, your LDL, your HDL, your triglycerides. You want to know your glucose and, if necessary, a hemoglobin A1C. And then you want to advocate for yourself. You want to recognize your risk factors and get them treated. Same thing with your cardiac symptoms. You want to know what the symptoms are of heart disease. And if you think you're having a heart attack, there's no hesitation. You should be calling 911, getting evaluated. There should be no embarrassment in that. If it isn't a heart attack, everybody's happy. And if it is, it gets addressed. So I think that's all I wanted to say on this. I'll pass it back to Mike.
Awesome. Yeah. So I should have said this before. If anybody has any questions, put them in the Q&A box. And one question that I have actually is, in general, like ideally someone's seeing their primary care physician yearly, but is there a point, or is there a certain number of symptoms or a certain number where, they need to ask their primary care physician, like, I want to see a cardiologist, right? Because, on this slide right here, like advocating for yourself, primary care physicians are great, obviously, but we want to get to someone who's an expert. So is there a certain point where people should be having that conversation with their PCP of like, I think I need to take the next step and have a cardiologist, see a cardiologist?
Yeah, I think that's a very individual decision. There are some primary care providers that are incredibly comfortable and competent dealing with these risk factors, and are facile with the medications, are able to switch them around, are able to give you what you need to get to your goal. And if you're with one of those primary care providers and everything is going great, there's no reason to ask for a cardiologist. But sometimes the primary care provider says, you know what? I can't get your blood pressure under control. Your lipids still aren't at goal. I don't have the time to deal with this. I'm sending you to a cardiologist. So if you feel that your risk factors aren't being managed aggressively and your blood pressure every time you come isn't at goal, or they're not changing your medications or adding them or manipulating them in a way that you feel is expert, that's a good time to say, I really want my numbers under control, and I really want to see a cardiologist to get this like buttoned down. So I think you kind of have to look and see what's happening with your care and be an active participant. And if you feel like everything is great and things are at goal, you don't necessarily need a cardiologist. The other time that people get sent to a cardiologist is if they're starting to develop symptoms. If they are doing their workout and all of a sudden they're more short of breath than they used to be, or they're starting to develop discomfort in their chest, that's a really good time to see a cardiologist, because then you want to get either a stress test or a CAT scan of your arteries that's more detailed, or some kind of further workup. So definitely with the onset of symptoms, that's a really good time to be referred to a cardiologist. But prior to that, it really depends on your comfort level and how your risk factors are being managed.
Awesome. Cool. Yeah. So if anybody has any more questions, throw them in the Q&A. And I know, Dr. Freed, you have a couple more slides, about sudden cardiac arrest in women. And obviously, for us being an AED manufacturer and being one of the treatments for sudden cardiac arrest, that's a topic that's very interesting for us as well. So I think why don't you do those slides, and then if other questions pop up, we'll answer them at the end.
Okay, sure.
Cool.
All right, go on. All right, so let's just spend just 4 slides, very brief, on sudden cardiac arrest in women. And since I'm talking about this, you probably already figured out it's different for women than for men. And I wanted to go over why. This is called the chain of survival. And it just goes through what could happen with a sudden cardiac arrest. Generally, when someone arrests, you want to have activation of emergency response. You want to call 911. And immediately you want to start high quality CPR, and we'll talk about what that is. And if an AED is available, defibrillation is also important if it's a ventricular fibrillation or ventricular tachycardia arrest, which the AED will help you figure out. And then, oopsie, sorry about that. And then there's advanced resuscitation that can happen once the ambulance comes. And then once in the hospital, there's something called post-cardiac arrest care, and obviously, hopefully recover, right? That's a chain of survival for sudden cardiac arrest. So in 2017, a study found that only 39% of women in cardiac arrest receive CPR from strangers in public, compared with 45% in men. Men's odds of surviving were actually 23% higher than women's. And bystanders hesitate to perform CPR on women, and these were the many reasons that were postulated. They were fearful of potentially inappropriate touching or exposure because it's on their chest, fear of being accused of sexual assault, fear of causing physical injury. Maybe the bystander was a man and he thought he would hurt somebody if he did CPR. Poor recognition of a woman in cardiac arrest, because again, if you're thinking women don't have heart disease, why would they have a cardiac arrest? So a perception issue. Misconception that the breast makes CPR more challenging. So these were all issues. But honestly, the chances of injury to CPR are generally low, and legal action is really unlikely because there are variations of Good Samaritan laws that offer protection in all 50 states. So there's very little that's going to happen to you as a bystander if you do CPR, and you will potentially save that person's life. So very important. And so CPR, what is CPR? There's something called hands-only CPR, where you can do 100 to 120 compressions per minute. There were ads a couple of years ago about doing it to the rhythm of Staying Alive, the song Staying Alive. That's about the right rate for that. And you're supposed to press down 2 to 2.4 inches for adults. And you should not stop until an AED arrives or until EMS arrives. So that should be a continuous thing. And you can trade off between people if you get tired while you're waiting for those things to happen. And so what is an AED? You've probably seen these boxes in public buildings or hospitals or even churches, schools. And it's basically this very clever machine that you turn it on. That's really all you need to do. You need to put the patches on, and it tells you how. And there's step-by-step instructions, so you don't have to know in advance how to do it. It's going to guide you right through there. And you can't hurt someone with it because it's doing the thinking for you. So if there is a rhythm that's appropriate to shock, and the two that I mentioned are the appropriate ones, an AED is going to shock that patient. And if it's used within a minute, the chances of survival are 90%. So absolutely, if you're with somebody who arrests, have someone call 911, start CPR, and see if there's an AED nearby that you can use, because you will save somebody's life that way. And that was my little blurb on sudden cardiac arrest.
Awesome. So a couple questions came in. Before we get to them, I just want to make a statement about it. For us as a manufacturer, I think, one thing we're trying to do, and we need to continue to do a better job of, is raising this awareness that, the stats are real. Women are less likely to receive treatment. This is why, and this shouldn't happen, right? Because the treatment is the same for men and women for sudden cardiac arrest. So I think that's an important role for us to take, in this awareness as, again, being a manufacturer of AEDs. making sure people understand that these are some reasons why women aren't receiving the treatment they need, and that needs to stop, right? We need women to be treated as quickly as possible with sudden cardiac arrest, because we know that yields the highest survival rates. Two questions that came in, I think they're back about the first part of the presentation, but first one is, my wife developed high blood pressure during menopause and has been prescribed a diuretic.
Mhm.
Has been effective, but is that an old-fashioned treatment method, and are there newer treatments?
Actually, that's actually the ideal first line medication, and the diuretic, I don't know if it's hydrochlorothiazide, but that's the one that I mentioned on the slide. It is an old treatment, but it doesn't make it an ineffective one. If her numbers are at goal, meaning they're, always less than 130/80 and ideally in the 120/80 range, then, and she's having no side effects, that's a perfectly valid and useful treatment. A lot of times people outstrip that over time, because as you get older, your vessel gets stiffer and you might need more medications. And actually, we generally will add on either one of two classes of medications after that. There's calcium channel blockers, things like amlodipine is particularly effective, or ACE or ARBs, which are things like lisinopril or losartan or valsartan. And those actually work really well in conjunction with diuretics. So if that's working for her well now, that's more than enough. And if she needs more later, there are ones that will work with synergy with the diuretic to help her control her blood pressure.
Cool. Next one is, this is the last one I have here. Is it possible to get a concise list of normal parameters? And I can answer the second part of this. And the second part of it is, and also a copy of this presentation to share with family and friends, please. So I might have mentioned this in the beginning, but we are recording this. This will live on our YouTube channel. I'll share it with Dr. Freed as well, but you will be able to see this whole presentation. So if you want to share it with friends and family, it'll be on the DefibTech YouTube channel as well. But the first part of the question, Dr. Freed, is not something I can answer. And the question was just like, is it possible to get a concise list of normal parameters, or is there a resource for that?
Oh, yeah, there are multiple resources for that. The American Heart Association has lists of normal blood pressure goals, normal lipid goals, glucose, for all the things that I talked about. You can find that on the American Heart Association. You can also find it on our Yale website. We have, publicly available lists of parameters and goals for all those cardiac risk factors as well. And I'm sure that, I'm pretty sure that the 2020 guidelines that I was talking about for women also is a publicly available resource. So that actually has those tables that I pulled also are available online as well. So there's multiple resources. Those are probably the top three that I would try.
Awesome. Cool. And it looks like that is it. So, Dr. Freed, thank you so much. That was so informative, and so well done. I really appreciate you taking the time to be with us today and share this that great information.
Thank you for having me. I enjoyed lecturing.
Yeah, and everybody, thank you for joining. Again, this will be posted. We'll have this within a week or so on our YouTube channel. So there's a ton of valuable information. So please feel free to grab it and share it with family and friends. So thank you, everybody, and have a great day.
Thanks.